Hello, my name is Dr. Dave Webster, and this is part of the ongoing video blog series about the travesty of lack of access to PET-CT in Ontario, our so-called evidence-based and patients-first healthcare system. This is Serial Cancer Rounds Part 2. Part 1 is on my video channel. You might want to look at that as well. But Cancer Rounds are where all the physicians involved in managing individual patients get together and decide what is most appropriate for them. But this particular subtitle in this video is called The Deliberate Increase of the Physical and Emotional Stress to Men with Prostate Cancer Living in Ontario, ultimately decreasing their quality of life and, of course, their chances of survival. Now, these are some of the people from Cancer Care Ontario whose job it is to block these people from PET, and they did not need to be physically present in that room to be felt. I mean, we all understood that if we dared challenge or contradict what Cancer Care Ontario would allow us to do for our patients, somehow we would suffer. Their individual threats and, in fact, hospital budgets have been threatened. So, I mean, it was incredible, surreal. I mean, almost every case we discussed, somewhere there would be a role for PET as the accepted world standard beyond Ontario's borders. So as I continued to challenge my colleagues about this, there was a palpable sense of frustration and ultimately embarrassment in the room. As physicians, we know that our primary role is to advocate for our patients. However, if we didn't pretend that we were living in the 1990s, these people would flex their muscles. So here's a case we were discussing. A 64-year-old male, history of prostate cancer. His prostate's been removed as part of the treatment, and therefore his PSA, or prostate-specific antigen level, should be around 0. But every 3 months he gets his blood test, and now it's over 10. Now, during that time, of course, we would be doing investigations we would only be allowed to do by Cancer Care Ontario. He would have had a CT scan, which is negative. He'd had a bone scan. This is like a nuclear medicine scan in general. In PET scans, we image sugar metabolism. In this case, we measure bone metabolism, but they're both negative. Now, of course, what this man knows, not in the room, but everybody also knows, is that he knows I have cancer present in my body, but the doctors can't find it. And the reason we can't find it is because he lives in Ontario. Now, but what do we also know? Now, here's an interesting article from the Journal of Nuclear Medicine in 2016, and this concept of oligometastasis. Now, oligo means small or small volume disease. So let me read this to you. Oligometastatic disease presents a unique clinical scenario in which patients have a limited number of metastases or sites of spread of cancer. There have been many preliminary studies that have evaluated aggressive therapy for this oligometastatic disease. The goal of aggressive therapy combined with effective systemic therapy in this scenario is to prevent further progression of disease and hopefully improve overall survival. Also note, imaging is critical. Now, for those who have prostate cancer, I have other very detailed videos on this, but the one I'm going to be talking about is gallium-68, prostate-specific membrane antigen, PSMA. And I can tell you, in 41 years of medicine, there has never been such an incredible move forward and a positive news for people with prostate cancer, both how we image and manage them if you happen to be in an advanced medical jurisdiction somewhere in the world. However, not if you live in Ontario. So back to this article, here's something about looking. These are people who don't know. Well, we have suspicion that they have cancer, but we've got to find it and get a biopsy. So we're going to compare MR, PET, and then a fused PET image with MR and CT, which one's available. Let me just read this. The cancer detection rate was 66% for MR, 92% for PET. But if you fuse PET with either MR or CT, it jumps to 98%. So let's just look at that. The government will pay for the MR test, which is only 66% of the time. I'm going to pick this cancer out. Yet they will not pay for the PET fused CT or MR, which is right 98% of the time. So let's look at what this means for a patient and how we would therefore use this gallium agent to find out where's the best place to biopsy. Now, this is a case of a 73-year-old male. His serum PSA is 38, so he has a prostate. We're looking for the cancer. This means there must be cancer. But he's undergone 2 of what we call transrectal ultrasound guided biopsies. Not a very comfortable procedure, you can imagine, waiting for that procedure, waiting for the results, and his doctors, and both biopsies are negative. Then he is allowed to have a gallium-68 PSMA fused scan. Here's the MR part, and there's the gallium part. They put the needle there, and guess what? It's positive. If that had been available the first time, we would have already known long ago what the patient had. It was prostate cancer, and we would have also staged him with those images, as you would see in my other videos. Now, you can stop this video and look at, but these are just some of the proposed roles for PET-CT and how we would what they're recommending should be done for patients with prostate cancer. That is, unless you live in Ontario. So what I want you to do is imagine you are this man and his family, and you're living in Ontario. So post-treatment, his PSA is undetectable, everybody's happy and relieved. You're going every 3 months, a little bit of stress, waiting for that blood test, but everything's fine. Right, and then you get the first blood test where the PSA is elevated, and now the worry begins. Now the wait for the next blood test is more stressful and dreaded, and it's hard to focus your thoughts on anything else. It keeps going up, and so the doctors do what cancer care will allow them to do, but there is no luck in finding the cancer. Now, to have a PSA of 10, this has probably taken maybe close to 2 years for it to get there, and you can imagine the stress and anxiety levels going up exponentially, and of course unnecessarily. But remember, what everybody knows is that he knows there is cancer in my body, and maybe it's growing more and it's spreading, but we just can't find it. And he knows that the later it is that we find him, the more likely there will be more disease, harder to treat, and therefore his overall chances of quality of life and survival will be decreasing. But let's consider what is available to prostate cancers living where governments don't just see prostate and other cancer patients as red ink on their spreadsheets. Here is a 60-year-old male, and actually lives in Ontario, but his PSA is now just 0.3. It's not 10, it's 0.3, possibly his first blood test where it was going up. But he goes to the US and pays for this PSMA scan, and here it is. Here we can see this is the PSMA on the bladder. Here is it squeezed the bladder. This is the CT. Now, that little tiny spot there, that's what we mean by small volume oligometastatic disease, and the rest of the scan is negative. This is all the tumor that is present in that man's body at that time. Now, who wouldn't want to know this information at this very early and potentially treatable, possibly curable stage? Well, I can tell you that these people don't want. You are now in their sights, just like breast cancer patients were in their sights in the early 2000s. Their job was to block women with breast cancer from access to PET, and we remain the only medical jurisdiction to this day on the planet that continues to deny that PET could be critically useful for certain women with breast cancer. They, I can assure you, are devoting now their efforts to discredit, delay, and block you from how PET is managed in prostate cancer in civilized, advanced medical jurisdictions. Now, so what happened? What could we recommend based there? So what do we recommend to this patient? Well, we started him on some chemotherapy on the speculation cancer might be present, and of course we'll repeat his CT and bone scans, which is all we can do. Now, my advice to this patient, and anybody with prostate cancer for that matter, is that you should consider leaving Ontario if you want access to a healthcare system where critical healthcare policies are based on the best available science, not based on an egregious political agenda directed squarely at you and your family members. We need to demand that these motions from 2005 demanding from the Canadian Association of Nuclear Medicine demanding an independent review of the ethics of how this possibly could have happened in Ontario take place immediately. And we need to do that, or either massive lawsuits, and these will be the only actions that will force Ontario politicians to stop the assault on patients like this prostate cancer and the rest of the cancer patients and dementia and other patients in this province. So here's my YouTube channel, my various video social media sites and internet sites, and so thanks for watching.